It's starting right now.
Okay.
All right, we're live.
Hello, everyone. Thank you so much for attending our very first shadowing session.
We are so excited the WebShadowers has finally begun.
Today, it's our pleasure to have Dr.
It's
Kagetsu,
starting right now.
a neuroradiologist, as our guest physician this morning.
Please remember that
All right,
the
we're
Google
live.
form will be posted in the comments at the end of the live stream.
Hello, everyone. With that being
Thank you
said,
so much
for attending our very first shadowing session.
We are so excited the WebShadowers has finally.
With that being said, Dr. Kagetsu, you may start sharing your screen whenever you're ready.
Okay, hopefully you can see it now.
We can.
Okay, very good. All right, so I'm going to be talking about neuroradiology, and here we go. We do CT, MRI, and plain films of the brain, spine, head, and neck. And the reason I like neuroradiology is that we use 3D thinking and logic to take better care of our patients. We also do some procedures. We have some patient contact. We do myelograms and lumbar punctures. And because of, if you have good technical skills, you can take better care of our patients. Okay, we're gonna start off with this slide. I can, okay, this is a woman that presented with weakness, and we decided to do, well, I can ask you guys, what test would you get for a person with, say, young woman with leg weakness? I can make it a multiple choice. Plain films, CAT scan, CT, or MRI. And hang on one second. A little technical, I'm sorry, so sorry. You know what, we'll just go on. So, well, we decided to do an MRI. CAT scan is very good for something like trauma, and you want to see if the bones are fractured. And so we did an MRI just to see the spinal cord better. So here we see the spinal cord. This is what we call a T2 weighted image. We see a spinal cord, and then we see this white spot in the spinal cord. And there's a differential diagnosis of what this could be. Sometimes people see a finding like this on the MRI, and they'll say, oh my gosh, that's a tumor. And that's potentially, hang on one second. So sorry. You know what? Okay, so this is, so we'll see it. There have been cases where this has been called a tumor, and the patient went to surgery and they had a biopsy, but in fact, it turned out to be multiple sclerosis. And so if this is multiple sclerosis, you shouldn't really be biopsying multiple sclerosis. You should say, you know, this could be multiple sclerosis. I guess it could be a tumor, but probably should sit tight and see if it evolves as multiple sclerosis. And you could also do imaging of the brain to see if there's lesions in the brain that also would support the diagnosis of multiple sclerosis. So the neuroradiologist has an important role to give advice to the clinicians to make sure that the patients don't get unnecessary biopsies. Okay, so that was multiple sclerosis. Okay, this is another case. These are CAT scans, and they're kind of like x-rays, right? The bone is white, the soft tissues are kind of just intermediate, and air is black. And these are CAT scans, and these are actually CAT scans of the temporal bone. So the temporal bone is essentially where your inner ear structures are. These are the inner ear structures. There's the external auditory canal. And these are a bit of your ossicles. And so anyways, this patient, say, was a 40-year-old patient that presented with pulsatile tinnitus. As you may know, pulsatile tinnitus is, well, tinnitus is ringing in the ears. Pulsatile tinnitus is ringing in the ears that that is synchronous with the heartbeat. And then there's actually two kinds of pulsatile tinnitus, subjective and objective. Subjective is when the patient is the only one that can hear it. And objective is if you put a stethoscope on the patient's head, you can actually hear tinnitus. And I've had patients, I used to do neurointerventional, and which is even more specialized form of treating these patients. And I put the stethoscope on the patient and heard essentially a loud whoosh, whoosh sound. I asked the patient, what does the sound you hear, what does it sound like? And he says, vroom, 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 something like that. So that's the sort of problem with pulsatile tinnitus. So when you do imaging for pulsatile tinnitus, you do a CAT scan, and we see this soft tissue in the middle ear. So this is the outer ear, the middle ear, where the ossicles live. You can't really see the tympanic membrane. The tympanic membrane separates the external and middle ear. Tympanic membrane would be something like about there. And then these are the inner ear structures. So we have a soft tissue mass in the middle ear. And these are two different patients. And in this, and you could argue that these images look kind of similar. You could argue, yeah, they're kind of similar, but they're actually very different entities. These are the axial images of the same patient. And you can see that this soft tissue is in the middle ear, and there's no connection with this soft tissue, which is the internal carotid artery. And you can see this piece of bone, we call that a bony carotid plate. And so this would be, in fact, a glomus tumor, glomus tympanicum, whereas this patient has soft tissue that is continuous with the internal carotid artery, and there's no, and in contrast to this one, there's no piece of bone. So the kind of scary thing that has happened is that patients have been, have been told, oh, you have a glomus tumor, and the surgeon goes and biopsies this, which leads to a lot of bleeding and potentially stroke. So it's very important for the neuroradiologist to, again, guide the surgeon to get the right form of therapy. So this is actually an anatomic variant. They call it aberrant internal carotid artery, where the carotid artery actually loops into the middle ear, can cause tinnitus, but certainly should not be biopsied. I've seen patients like this that have had a biopsy, and then we've actually had to sacrifice or occlude the carotid artery to keep things from getting even worse. So those are two entities. One's just a glomus tympanicum tumor, and one's the Aberrant ICA. Okay, this could be a newborn with high output congestive heart failure. So the high output congestive heart failure means there's so much blood flow that the heart can't keep up with the flow. So there's a short circuit in the circulation. So there's two places that a pediatrician will listen to. One is the head, and I don't know how much you've been shadowing other folks, but what other area do they listen to? There's two places. The other place is actually the liver. So there's two places where neonates can actually have a fistula. One is the vein of Galen malformation, and the other is a hemangiomas that cause a short circuit of the blood in the liver. But I'm a neuroradiologist, so I'm going to show you the brain. So this is actually a variant of the vein of Galen, where the blood vessels from the vertebral artery are shunting rapidly and filling this dilated vein of Galen and then dilated venous drainage system of the brain. I had been involved in folks that, again, the neurointerventional folks get involved in treating these lesions, very challenging lesions to treat. Okay, let's go to one more. So that was a vein of Galen malformation. Okay, so this is a patient that had left-sided thigh pain. So the thigh, and this is the lumbar. This is the sagittal plane. These are axial cuts through about this level. And so you see the, so this is the L3 vertebral body. This is the pedicle. This is the L4, you see the pedicle. And so at a more normal level, say 2-3, we see the L2 nerve root, and we see the L2-3 disc, and you see the white stuff is fat, and you see fat in the foramen and the nerve root. At this level, you don't actually see the nerve root, and the fat is obscured by disc material. And here's a 4-5. It's maybe a little narrower, but you still see the L4 nerve root surrounded by fat. So this disc is a disc herniation that is putting pressure on the L3 nerve root and causing thigh pain. On the axial image, you can see the symmetry, or the asymmetry, I should say. So here's the spinal canal with this is the thecal sac that contains the spinal fluid. The spinal fluid is white on the T2 image. This is a T1 image. The fat is bright here. And you can see this is the nerve root. So this is 3-4. This is the L3 nerve root. But again, the L3 nerve root is obscured by the disc material. Okay. And that was just a simple disc herniation. So this is a kind of an anatomy review. One thing, to me, sometimes what you may see in medical school regarding blood vessels is almost a cartoon, and it's kind of interesting to actually see real anatomy and real people. And this was a patient that was probably getting worked up for a stroke or transient ischemic attack. So we did an injection of the carotid artery. We used a catheter. When I was being interviewed for medical school, they said, "What is a catheter?" And so I said, "Wow, it's just a small plastic tube." And I should have said something like, "Well, doctors use the term catheter because they can charge more." But anyways, it's a small plastic tube. We put it in the common carotid artery. We injected contrast. And the thing we're not seeing here is the internal carotid artery. The internal carotid artery is occluded. And then we're just directing all the contrast to the external carotid artery. So I don't know how many of you are taking anatomy, but there are simple mnemonics that we use for studying or memorizing the branches of the external carotid. One of the things I remember from medical school. I'm actually postgraduate year 37. So just in case, this is one of those things that still sticks even after all these decades. So one of the mnemonics is SALFOP-SI, SALFOP-SI. So you have things like the superior thyroid, So even though this blood vessel is directed inferiorly, we call it the superior thyroid because it's actually supplying the superior aspect of the thyroid gland. So that's S. The next one is A is ascending pharyngeal. That just goes straight up. And then the next is lingual. So actually, I should just give some background. This is a lateral view. So it's a lateral view from the side, and this is a frontal view. And these are, we use a kind of a technical trick called subtraction, so that the only thing we're seeing is a contrast in the blood vessel. And you can kind of see the ghost of the mandible right here. You can see the turbinates in the nasal fossa right here. This would be the nasal septum. And then this is actually the tongue. And there's technical reasons. Well, so ideally the patient is perfectly still for this subtraction technique to work out. And as you can imagine, it's hard to have your tongue perfectly still for a long time. You just swallow and that sort of thing. And so the tongue moved, and so you have this artifact on these images. But that is kind of a hint to what this vessel is. This is the lingual artery. And the lingual artery, there's two of them, and they kind of come up and they don't quite get to the midline. So that's why I think that, when people get tongue piercings, they get them in the midline because presumably they don't want to hit the lingual artery. Okay, so that's sal, then fop is facial. So the facial is this artery, and it's probably one of these kind of, it's easier to see on this view. Let's put it that way. So the facial artery actually goes to the nasal ala. And one story I use to remember that is one of my colleagues was doing embolization of the nasal, for epistaxis or nosebleeds. Embolization is when you put in small particles to plug up the blood vessels, and they embolized the facial artery, and the nasal ala became ischemic and sloughed off. So that was a bad unintended result of embolization. O is occipital. So this is anterior, this is posterior. So this is going posteriorly to the occipital region. And it's harder to see on the frontal view. And P is posterior auricular. You hardly ever see posterior auricular on any imaging, so that's probably one of the reasons I save these images. This is the best example of the posterior auricular I've ever seen anywhere. And then the last two branches are the superficial temporal. This is the end of the external carotid artery, and then this is the superficial temporal artery, and it has a little wiggle here anteriorly and keeps going up. The superficial temporal artery, you can kind of follow it on this image. This is the end of the external carotid artery. And one of the ways you can tell it's superficial temporal is that on some of these images, it's external to the skull. And this one is going to head off and be external to the skull. This is the internal maxillary artery. The internal maxillary artery, and you can see that would be this one here. And the internal maxillary artery is probably the main culprit for epistaxis. So I used to treat people with epistaxis. So you'd guide the catheter all the way up here. You make a few turns, avoid a few wrong turns, and you put the catheter tip about there, and then you inject particles and treat epistaxis. There's one, and so that's the branches of the external. There's one bonus branch here. This is a branch that goes superiorly, and then it cuts kind of anterior. And this is the same vessel on the frontal view. It cuts a little anterior and lateral. And it actually, a hint is, this is the foramen spinosum. So I don't know if anyone wants to comment on what vessel that might be. And while you're thinking about that, someone asked what the general hours are as a neuroradiologist. Well, as an attending, there's various, you know, I actually work 4 days a week and have, and in some ways it's kind of like ER or other specialties where it's almost like shift work. You have a shift where you're supposed to read all the cases. So my typical shift would be 8 to 5. Sometimes I cover some of the evening hours and it's more like noon to 8. Today I'm actually starting later, like 2 to 11. So we have various shifts we cover, and in some ways it's nice because you, and I know some anesthesiologists that are like the fact that when they treat a patient, they're kind of, and then they're completed their day, they're kind of done with that patient, and usually there's no kind of follow-up. So I kind of read my case, and there is that kind of feeling that, okay, I've finished that one. And, you know, sometimes you'll see it again, but for the most part, we generate, for the most part, we generate a report and we're done with that particular patient. Majority say self SI. So this vessel, so let's get back to this vessel. This vessel is the middle meningeal artery that goes through the foramen spinosum. Okay, that's enough vascular anatomy for this. And these are the two mnemonics. Some people say, oh, that's like System International if you're into the metric system. And then this is whatever, MS. And this would be superficial temporal internal maxillary, and then internal maxillary superficial temporal. Just different ways to memorize it. Okay, this is a patient that has kind of subtle findings. Let's say it's a patient that showed up with a headache, maybe went to an outpatient clinic, and then came in for outpatient imaging. And the one thing that perhaps is striking is this kind of rounded structure here. And then if you use your imagination, you can see CSF here. Well, first of all, let's start off, this is a CAT scan. And then you can see that there's some asymmetry, right? There's kind of a vague kind of soft tissue here. And the thing is, what do you think that is? So somebody said, what made you choose neuroradiology? Well, radiologists, it's kind of like solving puzzles, right? I like puzzles, and so this is kind of a puzzle. And so these probably are blood vessels. You could argue they're veins, because if vessels get enlarged, which vessels get enlarged more, arteries or veins? It's usually the veins. So if you see round balls, it could be an artery in cross section, or a vessel in cross section, and so probably a vein. So this is the same patient. This is an MRI. This is a T2 weighted image. The CSF is white, and flowing blood causes an artifact called signal void, and you can see this is the lesion. So one of the reasons actually I like radiology is I did, my background was in chemical engineering, and I liked physics, and to me there's a lot of combination of radiation physics and in use of physics and logic in radiology. Some people like radiology in spite of the physics. I actually like radiology in part because of the physics. So now we see this lesion with a signal void. That means there's high flow blood vessels. And so this in fact is an AVM. Is the corpus callosum missing on these images? We don't see it, but that's because we're below the corpus callosum. So good question. I don't have a sagittal for this particular series. this is the AVM is a short circuit of blood vessels. You have an artery. This is probably the middle cerebral artery supplying the what we call this the nidus. And then we see one of the draining veins going back to this is called the basal vein of Rosenthal. And so this is deep venous drainage. And sometimes we map out these lesions very well so that the interventional team or the surgeons can create a plan to treat the AVM. So brain AVM. We could probably have a whole talk on brain AVMs, and I could probably, but that's another story. This is a patient. For HIPAA purposes, it comes out dummy patient name, so we're not trying to be insulting or anything. And this is an interesting patient that had tinnitus. So this is another case. And we try to get, these are CAT scans. And so to me, one of the cool things about radiology is that, we're looking at, you kind of develop a search pattern. And this is the temporal bone, so-called petrous pyramid. And you can make out some of the anatomy. These are semicircular canals. This is the top of the superior semicircular canal. But I showed it mainly to show the symmetry of the occipital bone. So if you look at these two occipital bones, you could argue that's a suture, but you could argue on this side, there's more lines going through the bone. So I thought this was an interesting case because this patient, we just talked about the occipital artery. This patient has a fistula from the occipital artery to the transverse sinus, which lives roughly about here. And we call that a dural AVM. And so just that kind of subtle observation of the, many people will be just looking at the bone, but you have to be looking at the occipital bone and this asymmetry. And the confirmatory test for this patient would be to do what we call an MRA. An MRA is a MRI with here's the MRI, or the MRA, I should say. And some of these, and this is seeing all these vessels in a different way. This is the occipital artery on the normal side, and the occipital artery on the affected side. You can see it's a little too busy here. And then this image is made from a bunch of these so-called source images, and we're seeing that they're shunting. These match those bony channels we saw earlier, and there's signal or flow in the venous side. So we know that there's abnormal shunting going on, and then these can be treated by the neurointerventional folks. And so this patient's pulsatile tinnitus was not from a glomus tumor, not from an Aberrant ICA, but from a dural AVM. And this is just a comparison to try to kind of match up. This is the sigmoid sinus, and we're trying to get comparable cut sigmoid sinus, and some of these channels would match up some of these channels. So it's kind of a complex case. I don't know, they probably spend about 10 minutes on this, if that in medical school. But I think in some ways that's the cool thing about neuroradiology. You have this specialized knowledge that can help selected groups of patients. Let's see. So I can take time and answer, how has COVID impacted my work? So I'm actually lucky in the sense that I can work from home. So I'm actually working from home. I can work from home, and some of my colleagues are actually doing work that requires direct patient contact, but like doing lumbar punctures and that sort of thing. But yeah, I can work from home. And initially, when COVID hit, as a lot of people were staying outside of the hospital, and so the volume of studies dropped, and some people were affected by that. But the volume of studies for neuroradiology is actually picked up and is pretty close to baseline. MRI and MRA. So MRI, let's see. So MRI images are typically like a 5 millimeter slice. And an MRA, let's see. The MRA we take, these are like 0.6 millimeter slices, and they're not as aesthetically that pleasing because they're so thin. When you get slices too thin, you get higher signal to noise. But then when you kind of do post-processing, and it's an algorithm, if you really want to get into it, you can look up MIP, multiple maximum intensity pixel ray tracing algorithm, and then you create, so like for the whole brain, we took all the axial images like that, and we just compressed them, and you get kind of this overview. And so MRA is kind of a cousin of MRI. And then one of the interesting things with MRA, we use tricks to get signal from the flow without using contrast. So that a lot of even junior physicians think, oh, MRA, we have to give contrast. And the thing with contrast is that sometimes people have allergies, or it's just one more step. And so it's kind of a cool technique that you can have, before MRA, to get an image like this, you had to stick a catheter in the blood vessel, typically the groin, inject contrast. The patient had a risk of stroke. So MRA has been actually pretty cool and revolutionary. And it came to be in, I would say, the 80s. And we were first learning about MRA. So I'm lucky in that I got to see MRA essentially from the first time it was introduced, and have seen it evolve. Hope that answers that question. I actually have a website that has some neuroradiology stuff on it. I don't know if I included that in the credit or in the final slides, but we can talk about that later. Okay, this is a patient that they thought might have had sinusitis, and I actually had a ENT colleague that showed me images that said, hey, there's this a pacified, this is the sphenoid sinus, and there is fluid in the sphenoid, and the ENT surgeon says, I want to go and drain that fluid because I think it's bothering the patient. And it was not this patient, but a similar patient. And then I said, this patient, that fluid is actually connected to the CSF, and that fluid may in fact be CSF. And so they said, oh, thank you so much. I think I'm not going to operate on that patient. And so this patient actually has temporal lobe that has kind of gone through a bony defect. And so we call this encephalocele, because there's brain that's kind of where it's not supposed to be. And it looks like on the other side, there's a smaller encephalocele and a bony defect. So this is a patient had a congenital defect of the bone, and over time, brain has pushed through that defect, and you have CSF. So this this patient needs more than just ENT. If they're going to fix this, they're going to have to get neurosurgery involved and everything else. If I were picking a specialty today, would I still choose neuroradiology? Absolutely. It was very interesting in medical school. One of my neurosurgeon kind of mentors or teachers kind of said, if I had to do it over again, I would have been a neuroradiologist. And that was just as MRI was coming out. And neuroradiology changed dramatically when CT came out. And then what is the average age of the patients? We treat the whole spectrum. There's even a subspecialty pediatric neuroradiology if you just want to deal with kids. Some of my colleagues have done fellowships in pediatric neuroradiology, but we get trauma on young patients. So, I treat essentially from teenagers to people in their 90s. In what ways has the field changed since I joined? So when I was a resident, well, the radiology actually is almost the poster child for change and managing with change. And so there's been several changes. One is the introduction of PACS, the picture archiving and communication system. So when I was a resident, a big part of the resident's job was, collecting films and dealing with films, putting films on view boxes, taking films down, getting them from the file room. That's all gone away. It's all electronic. So much of the scud of radiology residency is gone away. So PACS was a dramatic change. When I was a resident, we would use cassette tapes, right? We'd make a dictation and we'd it's on a cassette tape. We put the cassette tape with a stack of papers and a transcriptionist would transcribe them. And then sometime later you'd see the report and kind of try to figure out if there were any typos. And one day I remember from residency, the transcriptionist said, your tape just has music playing on it. So I don't know what happened, but I just had to do all that work over because the tape, sure enough, had whatever the tape they brought to me had music playing on it. So I don't know what happened in that particular case. So now we have speech voice recognition. I just have, actually I'm using the microphone here as my microphone for this talk. And we have voice recognition. And so we were kind of first adopters in the medical space to use voice recognition. And now I know radiologists that when the voice recognition system may have gone down in the early days, they would actually be refusing to use tapes because they like voice recognition so much. So, and some people thought voice recognition would be the end of radiology education, but we've actually found ways to have the speech recognition help radiology education. One thing that people have been talking about is radiology and artificial intelligence. I have a slide coming up later that, to me, artificial intelligence is not going to replace radiologists. Like I think President Obama even said something like that. If anything, it will supplement, it may make us more efficient and it will supplement what we do, but it certainly won't replace radiologists. How do you work with surgeons to form a diagnosis? Well, we give the surgeons, and most of the time we give the surgeons a report or neurologists, and then sometimes if they have a question about the report or disagreement, they call us up and we look at the case together. And I can even do that from home. The neurologist will text me, I'll text the neurologist. Sometimes I want to get a hold of a neurologist and tell them that, something important's happened to their patients. I'll just text them or email them. And it's very important to, you're definitely a key part of the care team, or stroke codes. So a person will have a stroke, and as you may know, it's very important to get things done quickly. So I'll be on the phone with the ER trying and talk to the stroke attending and so, in some ways, some people like, I like dealing with patients and that sort of thing. And that's, I can see that, I guess, but sometimes I actually like dealing with the neurologists and neurosurgeons even better, because you're talking to very smart people and you have kind of high level conversations, and I kind of like that. How long was the residency? Residency for you guys would be 1 year prelim year, 4 years of diagnostic radiology, and the fellowship is 1 to 2 years. What are the privacy concerns, both with voice recognition and digitization? Actually, the privacy concerns existed even in the film days. And in the film days, we weren't so aware of HIPAA, and you would go to national meetings and people would make slides of the plain films and you'd see patient information, and it was kind of uncool, and now it's more illegal. So yeah, we do have to be aware of things, or even one of the issues is, I would say voice recognition is not so much the issue, but it's certainly images, and even issues with posting images on the internet is a potential problem. And there was recently an article about how when you save images from PACS, sometimes there's what they call metadata, which is that the file contains not only the image, but it actually has some patient information. So you have to be very careful that when you post an image, you're not giving up any of the metadata. And that one, a guideline is if you use any sort of patient image, it should be more than a year old. And even more than that if it's a very, very rare disease, because you can't, just think if you say, oh, look at this interesting case of XYZ I saw in the clinic, and that patient's family will say, wow, that was me. And even though you didn't actually say the name. So it is very important that we respect patient privacy, and you should put yourself in the patient's place. What would you want done? And I've seen some things on social media that were of questionable taste. It's all about respect. My major, and I went to MIT and I majored in chemical engineering, but I kind of knew I was pre-med, and but I did chemical engineering, so I kind of took a lot of other kind of more basic engineering courses just to kind of learn about engineering and science, and I thought it was a good background. And they kind of joke that chemical engineers the math majors would make fun of chemical engineers, say, oh, you're just plumbers. And so I thought it was ironic that, in fact, a lot of medical problems are essentially plumbing problems, right? Tubes get blocked up, or tubes need to be plugged up. So I do think it is a good perspective to have, and to be a good contributor to the team. Okay, this is another case. So this is a CAT scan. This we can tell because the bones are dense, and we can see this lesion in the posterior fossa in the cerebellopontine angle. And this is an MRI, a T2, because the CSF is white, and we see this same lesion, and it has kind of dark signal and bright signal. So this is actually an aneurysm. An aneurysm is like a weak spot on a blood vessel. My colleague would explain it to patients like on a tire. Sometimes you have a little bubble, and it's a problem because that bubble, if that bubble pops, that could lead to a catastrophic, even fatal hemorrhage. So this is an angiogram we did, and these are the vertebral arteries. This is the basilar artery. This is ICA, anterior inferior cerebellar artery, and you can see that there's relatively slow filling, because essentially it's slowly filling because it's a dead end. And this is the basilar and posterior cerebral arteries. And then one of the kind of side stories on this one is that this patient came to us at NYU because we were essentially tertiary referral center, and you can kind of make up the story. Some radiologist probably said, oh, this is a vestibular schwannoma, solid tumor. And the surgeon operated. They looked at this lesion, they said, that ain't no vestibular schwannoma. And they probably had some choice words for the radiologist. And so they closed, and then they sent the patient to NYU for assessment and eventually and treatment. And my colleague Alex Bernstein, who I'm grateful I got to work with essentially one of the kind of a father of interventional neuroradiology. He put a catheter and he plugged up the ICA and cured that patient. scariest case I've encountered. So that it's funny because some people, let's see, scariest case. There's scary cases with good and bad outcomes. There are certainly memorable cases. So I was a program director in radiology for like 15, 16 years. I'll put my contact info in the, or you folks can have access to my contact info, or you find me on Twitter and you can direct message me. Scariest case, well, we had a patient, a woman who was shot in the face, and she had bleeding from traumatic epistaxis. And as you may know, with a young patient, when their blood pressure starts to fluctuate, it's very ominous. In an older patient, the blood pressure kind of goes down slowly, but in a younger patient, it kind of fluctuates and then it crashes. And in this patient, it was kind of fluctuating, so we had to move quickly. So that was kind of an exciting day at the office. So I actually published this case for those interested. I can send you the paper, but it was in a case report, and we put in some coils and her pressure relieved. And then later on, somebody in the ER says, you know, you saved her life. And I didn't even really think about it, but I said, oh, I guess I did. So that was kind of cool. Had another patient with epistaxis, and it was from a giant pseudoaneurysm. And at the time we had no technology to fix it. So we futilely tried to fix it, but ultimately the patient died. So that was sad. So yeah, neuro IR definitely has some of my most memorable cases. Some would argue maybe too memorable, maybe. So I actually don't do neuro IR anymore, and I stopped in like 2005. How many cases do I go through in a day? So when I'm doing diagnostic imaging, I can do like, I don't know, on a shift, 40 studies I give reports on, and phone calls to clinicians and that sort of thing. And then regarding direct contact, when we do procedures, we explain the procedure, what'll happen, and make sure that they you know, if they're anxious, we try to do things so that they're not anxious, give them the result. When I do procedures, I would give haven't done procedures in months now, but I would give the patient my cell phone and, you know, be available to ask questions later and learn some interesting things. They hardly ever call me, but sometimes they call, or sometimes they'll call me just frustrated with the system, not being able to find their clinician. So I help them find their clinician. I figured it's the least I could do. And some of my colleagues actually, you know, for tumor follow-up cases, they've almost become the go-to neuroradiologist for that family. So the family wants to, after the study is done, my colleague would meet with the family and essentially tell them hopefully the good news that nothing's changed. The tumor is still, you know, dormant. And on occasion, they'll have to tell them the bad news that, oh, it looks like there's something new. We'll get you connected to the surgeon and see what to do. So yeah, there are opportunities for direct patient contact. And then one of my pitches for radiology is that you can kind of, just by going into diagnostic radiology, you have a whole bunch of choices left regarding specialty. So some of the subspecialties have a lot more patient contact. Interventional radiology is now almost its own specialty, but that's almost like surgery. Breast imaging, they have daily patient contact. So yeah, it is. And so to me, this is the right amount for me at this point. So let's see. This is more of an ER case. I can check in with my team. We have 10 minutes, but we've been kind of answering questions all along, so we can go through this quickly, or we could stop. or we can just show this. How about a few more cases? Let's see, I want to actually, we'll do this one quickly. You know what, I'm just going to go to one important case. So here's artificial intelligence at work. This patient had a prior exam, and this is the current exam, and then the company we use is ADOC, and the company said, the artificial intelligence said, no intracranial hemorrhage findings detected by artificial intelligence. So my resident said, you know, this wasn't on the old study. I think this is hemorrhage. And so this is, you know, the ADOC does find some hemorrhages, but it does miss others. And I think I would want my study read by a human, and you know, just a comment about artificial intelligence. And then I can explain why did ADOC get confused? Well, so this is the falx, right? This is relatively high up in the head on a CAT scan. This is the falx, this is the central sulcus, this is frontal lobe, behind the central sulcus is parietal lobe. So along the falx, you also often have calcifications. So ADOC probably thought this was a calcification, but it's not. If it's a calcification, it should have been on the prior study, just like this calcification. So since it's a new finding, it's not as dense as the calcification, it's hemorrhage. So our resident thankfully described it, and we just chalked it up to you know, thank goodness for human eyes. We'll back up and go to this case. So some of my diagnostic image, or some of my diagnostic radiology colleagues make fun of neuroradiology, say, it's just symmetry. You just compare one side to the other, and that's the abnormal side. And I kind of jokingly say, yeah, unless the finding is symmetric. So this is a patient with trauma. So sometimes I know you guys like history of the patient, but this actually, in this particular case, the history is misleading because trauma has nothing to do with what we see here. And so that's one thing. We have to put all this kind of into our, think about, you know, take into the account the history, but there are times when we have to ignore the history. So this patient has this white dot here, right in the midline. This is a colloid cyst, and this patient a colloid cyst is actually causing hydrocephalus. So the frontal horns are kind of big, the temporal horns are kind of big, and the sulci at the vertex are small. So the colloid cyst is actually potentially dangerous because they can get acute hydrocephalus. And as you may know, your brain makes about half a liter of CSF a day. So if you plug up the works here, it can rapidly dilate the ventricles and essentially kill the patient. So there was a story where about an undiagnosed colloid cyst in a nursing student that went to the ER with a headache, and she wanted to go home because she was supposed to graduate the next day, go to her graduation the next day. So they sent her home, and she never made it to her graduation because her ventricles inflated, and she herniated and died the day before her graduation. So it's in some ways, neuroradiology is good because there's high stakes cases, and you can make some decisions that are very important to a patient. So that's a colloid cyst. This patient has a headache, nausea, and vomiting. This is actually very relevant for the COVID era. And you look at this case, and you see this is the vein of galen, and this is the superior sagittal sinus. And you could argue the superior sagittal sinus is denser than the galen, so this is thrombosis. A lot of our COVID patients are presenting with just venous thrombosis. It still really gets me. So I'm in the epicenter of New York City. Our peak was at April 6th, and now we're down to less than 1%. And it's just mind-boggling that people say that COVID is a hoax, that these images from New York City were from actors. It just, I can't take it. Anyway, so this is suprasagittal sinus thrombosis. It's important to make that diagnosis because the patient should go on heparinization, and for some cases, the neuro-IR team actually retrieves the clot. This is a patient, 40-year-old, presented to the ER with headache. And this is a relatively subtle finding. So the subtle finding is that there's high attenuation in the sylvian fissure. And then this is actually an interesting thing. One of my residents said, oh, that looks like a sea turtle. There's flippers, that's the head, that's the shell. And they said, oh, that looks like a sea turtle. Well, the fact that it looks like a sea turtle means that there's subtle attenuation in the suprasellar cistern, and this is subarachnoid hemorrhage. Sometimes these patients are sent home, and the subarachnoid hemorrhage is from an aneurysm, right? So if they're sent home and the aneurysm ruptures, we really did a disservice, because this patient, this is a real emergency. They need to, we need to find the aneurysm and treat the aneurysm by neuro-IR or neurosurgery. And that's the scary thing. If they just have a headache, they may get sent home. This is a patient, a CAT scan of a patient with hemorrhage. This is a hematoma. This is the suprasellar cistern filled with hemorrhage. And this is another aneurysm. And we're near the end of our time. So this is my email. You can email me. This is Twitter. This is another neuroradiologist on Twitter that posts interesting cases. ASNR is only not quite free for undergrads. I think that's, for some reason, I pulled up an earlier version of my slide deck. But with that, I'll turn it over to the moderators. Any last questions, comments? Oh, I'm willing to stay online and take any other questions as well.
Thank you so much, Dr. Kagetsu, for your time and your wonderful presentation. It was an honor to have you as our guest speaker. Everyone, make sure you go check him out on his socials.
Additionally, thank you all for attending. The Google link form has been posted in our Instagram bio and in the comments. So please fill it out within the next 30 minutes for us to receive verification of your attendance.
Please keep in mind, you are responsible for tracking your own hours. We are just here to verify them when contacted to do so.
Please feel free to stick around and ask Dr. Kagetsu any additional questions you may have. If you don't have any more questions, you are free to go, but make sure you fill out the form.
We hope to see you soon at our next session tomorrow, 8 p.m. EST. Take care.
Dr. Kagetsu, you can continue answering the questions.
Okay, very good. Yeah, thank you. Yeah, and whatever feedback, I'd be interested in seeing what they all said. I must apologize. I actually made some modifications to the slide deck, but somehow pulled up the wrong version, but hopefully it was okay. Because I did take some of your comments. I made separate slides for history and whatever. I don't know if I didn't save it properly or what, but oh well. At some point you could, well, this is a very super specialized field, but neurointerventional and interventional radiology are probably might be of interest for your group. I think interventional radiology is actually one of the most popular specialties.
Dr. Kagetsu, we're typing the questions in the chat box.
Oh, okay. Where is the website? Okay, let me find it. So I have this site. I can send you the link back in the chat. So you can also just Google Kagetsu primer, but this is the link. Regarding DO students, depending on the residency, I mean, it potentially is an issue. I think DO students know that some schools are still discriminate, and it's terrible. But some of our, at Mount Sinai West, where when I was a program director, some of our best residents were DO students. So you have to kind of do some homework on that. Copy of the presentation. I can send you a HIPAA compliant version. One way to make it HIPAA compliant is I can just make a PDF. So I can do that. The one about Elon Musk is, that's too hard for me. So there's interventional radiology, there's neurointerventional, and essentially diagnostic radiology. So in so let's do that one first. So interventional radiology is essentially the main folks they work with are surgeons, general surgeons. So they'll like, or things below the neck, basically. They'll treat what do they do? They'll do tips, right? They'll put in IVC filters, take out IVC filters, that sort of thing. And neurointerventional is when you treat, usually it started out with vascular lesions of the head and spine. And neurointerventional would treat like AVMs. And now their biggest business is stroke. They retrieve clots and make dramatic differences in people's lives with stroke. And diagnostic typically does imaging. I mean, we typically do imaging and help people come up with a diagnosis. Interventional folks are the ones that sometimes do the biopsies, and sometimes diagnostic people do biopsies too. So there's kind of a crossover. When I was in medical school, I actually did an elective in neuroradiology, so I was kind of leaning toward neuroradiology. One of my uncles was a head and neck radiologist at Mass Eye and Ear, so I guess I kind of was thinking about that all along. How often do you see cases that you aren't familiar with? So it's interesting that, I consider that a plus, because I think there's always a new problem to figure out, something that doesn't quite make sense, and you're trying to figure out new things. I remember when I was a neuroradiology fellow, urologists would say, I've just been doing the same thing for 30 years. And I was like, wow. But to me, that every few years something new comes up, or even with diagnosis, some entity comes up. Even since I've started, they've come up with things that we didn't quite understand. Now they understand, like the entity press came out since I finished training. So I think I'm always learning, and it's a cool specialty. Is there an imaging technique that you think is superior to others? That's almost like asking about a favorite child, but certainly plain films are fading away because they have limited utility. And sometimes you, for example, CTA or versus MRA, you could argue which one's better. I think they are complementary. You know, they're just based off of different physics, right? For if the issue involves bones, then you need CT. But on the other hand, if it involves bone marrow, you need MRI. So sometimes you need both.
There are no more questions, Dr. Kagetsu.
So we're good? Okay.
Yeah. Thank you so much.
Thank you.
Okay, thank you.
It was a pleasure to have you as a
Oh
guest.
no, it's an honor to be the first in your series.
Thank
And I can. Do you want the PDF or?
Yeah. If you send us the PDF, we can put it somewhere that they can access it. We'll find
Okay,
it.
that's fine. Cool. Okay.
Thank you so much.
Thank you.
Thank you.
Bye
Take
now.
Have a
care.
nice day.
Bye bye.